I am Valentin Fuster from New York, and again it's a privilege to be sitting here with a group of intellects and to have a discussion about what is going on in this meeting, the American Heart Association scientific sessions, which they are closing in a few hours, and we have a lot to talk about it. So I'd like to introduce these individuals that I'm sure are recognizable to all of you. In my right is Dr. Lars Wallentin, who is professor of cardiology at Uppsala University in Sweden. Next to Lars is Dr. Noel Merz, director of the Women's Heart Center at the Preventive and Rehabilitation Cardiac Center at Cedars-Sinai in Los Angeles. Roger Blumenthal is next, professor of medicine and director of the Johns Hopkins Cicerone Center for Prevention of Heart Diseases in Baltimore. And now in my left is Dr. Sunil Rao. You're the youngest. Welcome.
Thank you.
Assistant professor of medicine at Duke and director of the Cath Lab at Durham VA Medical Center in North Carolina. Renu Virmani, nobody knows her. I have to make a long introduction. Anyway, you all know her. She has been in this program again and again. It means you are doing very well. Renu is president and medical director of the CV Path Institute in Gatesburg in Maryland. And finally, and not the least, Dr. James Young, chairman and professor at the Cleveland Clinic in Cleveland. Well, here are the experts. Let's begin to talk about what happened in this meeting. We were just saying a few minutes ago that were about 16 studies that were presented, breaking trials. And from these 16, 9 of them, I call them negative, and James already interacted with me saying, what do you mean by that? So I don't want to go into more details. But certainly there were about 6 that really may change practice. So let's now focus into 3 of them that perhaps were the most interesting ones. And so we will discuss the first one related to antithrombotic therapy. We'll discuss the second one related to medical therapy in cardiac failure. And then we'll discuss the last one related to a molecule that we have been talking for years and we are not touching, which is HDL. So let's begin with the antithrombotic one. The study I'm referring to is the ROCKET AF study. Basically, as you all know, atrial fibrillation is a thrombogenic phenomenon where anticoagulants, oral anticoagulants, have been used for years very successfully. But the INR changing constantly, patients don't like it. Now we have oral agents that are actually competing with each other. All are coming at the same time. Today we are going to describe the first 10A inhibitor that has been used in atrial fibrillation in comparison with Coumadin. And this is the drug called rivaroxaban. The study was presented under the auspices of Duke University. It was presented by Dr. Kenneth McAfee and Dr. Keith Fox from the United Kingdom. And the study is really very interesting for discussion. This is unique because it's a double-blind study having Coumadin as one of the arms. This is almost unheard. More than 14,000 people, I must say 3/4 of the people are from developing countries, which is another interesting aspect of the study. These were patients, of course, with atrial fibrillation they were patients at high risk. They had at least 2 risk factors of CHAD just to enter into the study. 55% had prior stroke, and 90% had hypertension, with a CHAD score of 3, which is one of the highest that we have seen. So this is a very sick population, or population at a high risk. These 14,000 people were randomized into rivaroxaban once a day, interesting, 20 milligrams, 15 milligrams in patients with moderate renal failure or renal impairment, better say, or to dose-adjusted warfarin at an INR of 2 to 5. So from the beginning, this is a very interesting study, the way it was designed. What about the results? The results will lead to some discussion, because overall, maybe we are all under the dabigatran. That was the first one, oral agent, that almost, I don't want to say fully, almost beat Coumadin. So now everything that comes after, it looks to us as secondary, not so good as we expected. Well, looking at the data, at the primary endpoint, which was stroke and non-CNS embolism, certainly the non-inferiority with warfarin was accomplished. When it was looked at superiority, it was accomplished, superiority to warfarin, only if you look at patients that were on treatment. At the moment that you move into a superiority with a primary endpoint being intention to treat, there was no superiority. Something that to me is a little bit odd, that we really have to discuss. Are people, when they leave taking the drugs, all the events are happening in one arm and not in the other? And why this is the case? Because this was a blind study. Anyway, this basically is a positive study in terms that is not inferior to Coumadin from the point of view of thromboembolism. What about hemorrhage? In terms of hemorrhagic stroke, the drug did well, 0.26 versus 0.44 per 100 patients a year, 0.26 for rivaroxaban and 0.44 for warfarin. And then when we look at the bleeding in general, measure and non-measure bleeding or measure bleeding, there was no significant difference. Intracranial hemorrhage was slightly lower in the rivaroxaban group versus the warfarin group, 0.49 versus 0.74. So this is a study that is very interesting in the way it was designed, people at high risk. Then is a study that when you look at superiority with intention to treat is not working so well, but when you look at superiority who was taking the drug is working well. In hemorrhage, there is no much difference with warfarin, perhaps some advantage in terms of intracranial hemorrhage. Well, Lars, you are very much in the field. Give us first, without many details, how is your soul?
Well, I think the investigators took on challenging patient populations. So, I mean, no one previously have studied such a high-risk population, and therefore we have really difficulties in finding another study to compare to appropriately. And they achieved their primary objectives, so obviously we have a new compound that can be used as an alternative in high-risk patients. It's non-inferior concerning stroke and systemic embolism, and there is no increase in bleeding. So from that perspective, the trial is positive, and we have a new strategy that can be used. It is a first TNA inhibitor that has been compared to warfarin. But I think the expectations were higher than that, and that's kind of the problem. So the expectations, of course, having seen the RELY trial and the bigatran coming out with a reduction in stroke and systemic embolism, and in combination with that also reduction in severe bleeding and a clear superiority beyond non-inferiority. And the expectation has since long been that the TNA inhibitors would be better than the thrombin inhibitors in this setting. So therefore, coming out with a result that's kind of non-inferior, without clear superiority and without a gain in bleeding complications, that's a bit disappointing.
Sunil, you are from Duke. What your friends, are they all excited?
Yeah, I think they are excited, and I think there's reason to be excited. I think that it's difficult to compare these two compounds. It's a different patient population, it's a different mechanism of action, it's a different trial. But I think that Rocket AF has significant strengths as a clinical experiment. especially when you're talking about bleeding, if you don't have a blinded assessment, it's very, very difficult to put a lot of faith in bleeding differences if the trial's not blinded. So I share everyone's excitement about dabigatran or dabigatran, depending on what part of the country you're from. But I think that we have reason to be excited about ROCKET-AF. You know, from a scientific point of view, it generates a lot of discussion regarding the intention to treat versus the on-treatment. But from a purely practical point of view, having something that is as good as warfarin, that doesn't require monitoring, that's still once a day, and lowers your risk of intracranial hemorrhage, to me, is a significant advance.
It still can win Wimbledon. So it's not out.
I don't think it's out.
Roger, I have a problem with this study. I want you to respond. The INR was pretty low. In other words, the therapeutic time on INR that was approached was actually 57%.
Right.
Is this the real world, and you would say accepted, or is that you are blinding a study and you don't know exactly what you are doing? I just want to get into this blinding approach, which I have great trouble with Coumadin, because I don't think you control the patient as well as it would be with an open study. I'd like to react to that.
So I think even a lot of the good Coumadin clinics may only have patients in the therapeutic range 2/3 of the time. So being less than 60% is not that far off, but that is a concern. I guess the other issue I wanted to bring up is we know when people are in warfarin and they need surgery, there's ways to reverse it. I guess the one concern that we have with dabigatran and rivaroxaban is if someone needs surgery urgently, how do we reverse it? Do we give fresh frozen plasma? And what will the insurance companies do, at least in the next few years? Our patients certainly have been wanting to get off of warfarin for a while. So those are some other issues that we may want to talk about.
Although you may have seen at this meeting, they released at least a press release about the first time we actually have a 10A inhibitor reversal agent. It's a pretty novel mechanism that was released by the scientists at Portola Pharmaceuticals, a reversal agent for factor 10A inhibitors.
Good.
So I think that's a huge step forward. We don't have to rely on recombinant factor 7, which, as you know, has been recently reported to be associated with a high risk of adverse events. So that problem may be addressed. Obviously, we need to do the studies to make sure that agent is safe in other ways.
Renu, I'd like to ask you about this blinding business. You perform lots of autopsies. You are not blind to anything. But it's not a curiosity to have a blind study with Coumadin?
I think it's very hard to have done this, to have blinded study for Coumadin versus no Coumadin. The other drug, I find this very difficult to believe that it was truly blinded, that they said it was blinded, and that may be the reason why it was not, only 57% of the patients were in range. So I think, for me, it's hard. When you're telling you're blinding, totally blinding in high-risk population, I think for me, it's a no-no.
Okay.
It is. I mean, it might be appropriate to compare to the other trials what they have accomplished, and it has been in a double-blind trial in the U.S. in the Sportif trial in Sportif, which was kind of 5, 6, 7 years ago. TTR was obtained with 67%. So I mean, and also in the Rely trial, an open trial, 64%. And there is an ongoing trial, the Aristotle trial, double-blind. And we know very well that we will end up in between 60 and 65% because we are closely monitoring what's ongoing in the sites, and we are giving them feedback on their INR control. So I think the reasons for the poor INR control in the ROCKET trial, I think they can easily be understood because we see in trial after trial that INR control is dependent on the countries and the sites who are participating, and that's driving 60% of the variation. The same countries every time come out with the same INR control. And we can see it since the Sportif trial, since the active trial, since the Rely trial, and we will see it in this trial. And unfortunately, countries with less developed healthcare systems, like in Eastern Europe, in South America, in Asia, where they aim for lower INR levels, they come out with poor INR control. And to achieve non-inferiority in comparison to poor INR control, that's kind of questionable. That questions the whole result. Because comparing warfarin with poor INR control, you can as well compare it to warfarin with good INR control, and you will get a better result. And that's well known from registered data and from all the other trials. So I mean, that question will remain, and it will be continuously discussed.
Before
what
I ask
does
James
it mean?
a question to you, I'd like to perhaps to emphasize one issue here. On one hand, the INR is poor in many places in the world. And this is a reality that we should not accept, but it's a reality. What we have to do is to get into an educational program which people can check their INRs at home, as now is being showing up, and having reliable information, much better than what we do now today in the hospitals. That's number one. But the problem with all these trials is that many of them, there are so many countries in which INR has not been done properly that it's difficult to compare dabigatran with any other drug that we give when in fact the countries are different and the substrate is different. Anyway, it's just a comment. We need a lot to do with education. But James, there's something that maybe in your experience in cardiac failure you got into this sometime, is the intention to treat. Here it really cancels any superiority that was found when the patients were taking the drugs. And in a blind study, it's hard for me to understand the mechanism, except maybe there is a rebound phenomena if one stops the arm when the 10A inhibitor is given. I'm just like you
I absolutely agree with your observation, and I think the hypothesis, though, is right on. Now, you know, we've become slaves to clinical trials a little bit and clinical trial design, and one of my problems has been I want to know what happens to the patients that are taking the drugs and getting the therapies. So the issue of intention to treat, I think, perhaps has been overemphasized sometimes, and you hit the nail on the head, particularly in a lot of heart failure drugs. There is a rebound phenomenon, probably the best beta blockers showing that effect. So if somebody stops their agent for a particular reason, you can see, I think, a rapid rebound of major events occurring, and that's exactly what I think may have happened here. One other comment, and I'll disagree with Renu a little bit. You could argue that the reason that blinding was assured in this study was the lower INRs, because theoretically, you know, when I'm in a blinded trial and I'm dosing a drug that may have some bad things that could happen, I might take the, you know, foot off the gas pedal a little bit. I might be a little bit more conservative. You know, so there are other issues at play.
But I would argue with you, in that case, you're not really testing your drug, your known drug, in its optimal way.
Right. That gets back to Lars's comment, which I think is right on target.
It's absolutely true in third world. The problem is going to be that they don't really do INR very well, and therefore you don't get the results that you would expect.
Noel, there is a question that maybe you can provide some light. Now we have this drug coming out. Apixaban in March will come out with a big trial, Aristotle. Then we have dabigatran. Another 10A inhibitor is going to come out, I think, is also next year. And the patients are all different. We can say generically what Lars said at the beginning. This is a new era, new drugs are oral. This is a great advance. But how we are going to compare with each other? Let's assume you are in charge of a company that is making one of these drugs. Would you like to compare with another one, or you want to continue on your own?
Well, I think one of the things we haven't really talked about at all is translating to real care, and we haven't talked about cost. And to hear that it is non-inferior and non-inferior to perhaps not even an adequate test, yes. And the intention to treat is a real problem. I mean, we are slaves to clinical trials, but there's a reason for that. And we can do the post-phase 3 analyses after widespread. You know, we can do the observational stuff and see how much is consumed and do area under the curve. But this was a clinical trial, so you have to kind of stick with the clinical trial rules. So I guess to answer Valentin's question, if I were, in charge of a major healthcare system, I would be asking for more information about cost and about hospital visits, all of the things that are all of the costs of care that are not just the cost of the drug. And I'm sure one of the reasons countries with less resources don't do this as well, it's a resource issue. It's not probably a knowledge issue. It's probably, it's a resource issue. So sometimes a more expensive medication actually is a more cost-effective approach. But sometimes it's not, and that's what I would be asking.
Lars, you have any comment from your angle in Europe?
No, I think that the incremental benefit should be compared to the incremental cost, and that's a lot of discussion around that, not least in my country. And so it's very much discussed when introducing new treatments, what do we gain by this? And I think it will be more costly considering the patient population that's treated with warfarin today. That population is very well treated in my country and in some North European countries. But I think the big advantage might be that we will treat a new population. There are many patients stopping warfarin. We knew that after 1 year, even in real life care, 20 to 30% of the patients will not be on the treatment. And we also have many patients not accepting warfarin because it has a bad reputation and it affects your lifestyle. So coming out with these new treatments, we will treat AFib patients much more appropriately, and we will prevent strokes. And stroke rates are high, up to 5% per year in a non-treated AFib patient. Bringing that down to around 1% might be a real saving for the healthcare cost of a country. So I think we need to take all costs into consideration, not only the cost for the medication and the cost for the current population, because you will see a change, I think, in how you approach atrial fibrillation when you have these new treatment alternatives. So and I think we do better with several rather than one alternative, not only dabigatran, but several others. I mean, we have renal dysfunction, we have side effects of these compounds, and for the patients, for the healthcare system, it's good with competitors.
But I think one thing I would like to say is, we've used warfarin 50 years now, and we know everything about warfarin.
But still we use it so badly.
Well, we may use it badly, but we know its side effects. We know everything. We know
in all patients.
Ineffectively, we know how to use it effectively in all patients.
Yeah, but we are not
on the other
using
hand,
it
the new drugs, we don't know what long-term they're going to do. So those are some things you have to really
I think it's true, Renu. I have patients that are under Coumadin. They are so stable that I'm not going to go around and start changing things. So we have to be very cautious. But we are going to be treating more and more patients with atrial fibrillation with these new agents. First, I think the new guidelines from the European group, I think, is interesting. Age 75 has 2 points. And it's going to be at least more patients will be treated as the guidelines move into more aggressive approach, even in the type of chats before we might have been given aspirin. Well, I think I just like to finish by one issue, which is the issue of safety, safetiness, because the issue of hemorrhage is extremely important. Now, when I look what we learned in the last 3 years or so about hemorrhage in patients receiving this type of antithrombotics and in atrial fibrillation, there are a few things that are of interest. One is dabigatran did very well, and I think you commented on. The other one is the safety profile of apixaban, which was recently in the Averroes study compared with aspirin, was actually pretty good. So it seems to me that the safetiness is really moving in the right direction with these drugs. This particular one is still questionable because it seems very equal, except hemorrhagic or intracerebral hemorrhage appears to be lower. But I'm just pointing this out, that we are in the new group of drugs that not only are important because we don't have to check the INR, but I think are also meaningful because probably they are more favorable from the point of view of safetiness, and I think this is a big advance. Anybody else wants to make any comment, any further comment about this particular important study?
I could add on to the last comment. I think intracranial hemorrhage, that's one of the most common side effects leading to fatalities in the Swedish healthcare system. It is warfarin-induced intracranial hemorrhage, regardless of good INR control. And it seems, based on these experiences, that intracranial hemorrhage is caused by vitamin K antagonist. I think they have a specific downside, a specific property leading to intracranial hemorrhage by affecting many different mechanisms, which is not really the case with the specific coagulation factor inhibitors, neither 2A inhibitors nor 10A inhibitors, because we have exactly the same difference with rivaroxaban and dabigatran, and I think we will see the same, hopefully, with also apixaban. And the main concern when you pursue aid and atrial fibrillation patients to start prevention treatment, it is, can I, as a doctor, take the risk of inducing an intracranial hemorrhage? That's my main concern, because I persuade a person to go into a treatment. And if an ischemic stroke develops, that's the reason for that is a disease. But if there is an intracranial hemorrhage, it's my fault. So therefore, people will try a change, I think, direction of treatment and strategy of treatment because of this single issue. And they will prefer, and the patients will prefer, the new agents because of everybody is really concerned about the risk of intracranial hemorrhage.
Well, thank you very much. I think this is a good practical point about the future. Well, let's give to this drug a 7 over 10, if you're in agreement with.
Sounds good.
That's good.
I'm up for
Renu,
that.
but you're in agreement too?
I am in agreement. When intracranial hemorrhage specifically, and also that you can treat many more patients that you weren't treating before, and you would be able to prevent stroke. Stroke is one of the worst things to have. I think if I'm the patient, I would probably take.
Yeah.
Can I give the Duke Premium and give it an 8?
Yeah, well, we'll take one away for what it's probably going to cost.
That's fair.
We take the median, yes.
That's fair.
So it becomes 7.5.
Thank you. Well, let's now move into the area of cardiac failure. I found this study quite fascinating, which is the so-called emphasis HF study. Well, there is a history behind this. I still remember as a spironolactone, a drug that we use from time to time. One day came, that's the drug for cardiac failure. And I think it was in the RAILS study. This is about 6, 7, 8 years ago, isn't it?
It's actually September 2nd, 1999, the day my son was born, so I remember very well.
Longer than that.
God. Well, so a long time ago. And then came the Ephesus study where eplerenone, the drug we are going to be discussing today, was given in patients with myocardial infarction and significant left ventricular dysfunction. And we all learn about this. What is interesting is when you look at these patients with cardiac failure, how are being treated, not necessarily a large percentage are treated with these drugs despite of the data that we are presenting, although these were people with significant cardiac failure. Well, all of a sudden we now have this emphasis HF study, which is eplerenone, actually given in people who had less significant cardiac failure. This study was presented here in this meeting by Dr. Sanat from Nancy University in France, and co-investigator is Dr. Bertrand Pitt, which, if I recall, he was involved originally in the other studies. Well, the study was as follows. There were about 3,000 patients who were just in class 2 heart failure, but the ejection fraction was 35% or less. And these patients were actually randomized on eplerenone up to 50 milligrams daily or placebo, in addition to the recommended therapy for cardiac failure. And they're followed for a period of 21 months when the study was actually stopped because of a significant benefit by the drug. The benefit I find is quite striking. If you look at cardiovascular death and hospitalization because of heart failure, it drops from 25.9% in the placebo group to 18% in the eplerenone group, which is 37% relative reduction. Cardiovascular death from close to 14% to 10.8%, and heart failure hospitalization 18.4% to 12%. So the results are actually quite striking. One of the great concerns by using these drugs is hyperkalemia, and the results with potassium, the levels exceeded 5.5 millimolar in 11.8% of the eplerenone group, with 7.2% in the placebo group. Although we have to be very cautious, and we will talk about this. These patients were followed even weekly from the point of view of the potassium. So this is something that we actually have to discuss. James, before I ask Lars how his soul was burning or otherwise after the study, the Rocket AF, what about you with this kind of material?
Yeah, let me tell you, Val, this is a home run, maybe even a grand slam clinical trial in heart failure. Dr. Pitt has been pushing the aldosterone blockade hypotheses for a long time. Aldo is a bad actor, as bad as renin and the catecholamines for remodeling in the heart. And the problems with the Rao's trial and then Ephesus was the limited patient population. So Rao's was class 3-4. It was an older population. People forget that they were only patients well over 60 that were in that trial. And then Ephesus looked at post-MI heart failure patients. Again, a more symptomatic population. So they weren't terribly generalizable. But there has to be caution, as you alluded to. But I think that we can accept that observation of hyperkalemia and proceed with caution. I am bothered that even today, with the fairly robust information out, the use of aldo antagonists hasn't been very great in the heart failure patient population.
Too many medications to the patient?
I think the polypharmacy, number one, is the challenge. Number two, like managing Coumadin, Lars, it's a bit of a falderall to get somebody safely up on an aldosterone antagonist. Number three, the clinical trials were in a narrower patient population. I think those account for the reasons why we didn't see eplerenone and aldactone used more frequently. But we have to proceed with caution because the story of what happened with the Ontario database is very, very instructive. Shortly after Rao's came out, Canada being the good guideline-based programs and embracing inexpensive drugs and population treatment strategies that are important like this, saw the use of aldactone just explode, just take off in heart failure patients. And with that, hospitalization and deaths due to hyperkalemia exploded too. And there was a pullback and a withdrawal. So the issue of hyperkalemia is quite real here. But who can argue with a 48% reduction in heart failure hospitalizations? Who can argue with almost a 25% reduction in cardiovascular mortality over a 21-month mean follow-up period?
Noel, I want you to follow on the conversation we had before when we talk about Rocket AF. Now, frankly, I have a sense that this is a class effect. In other words, I'm not entirely sure spironolactone, which costs nothing. That's the same thing that this particular drug. I'm just presenting this to you because I think it's a real issue. I think the trial is fantastic. But the question is this the drug that we are going to be using?
Well, it's always a great question. I would concur that I think it's a class effect, and we'll have Jim weigh in as well. you know, these other aldo antagonists are not as well tolerated. And I think that that's generally true of newer drugs. This is what makes money for the pharmaceutical industry, is they figure out a pathway. We do the research, a pathway's figured out, and they go back to the drawing board and get drugs that are more potent, more selective, and typically better tolerated. This is a perfect time then to take this, sounds like a grand slam, somewhere between a home run and a grand slam. I don't play baseball.
Maybe a home run with one guy on base.
But again, to look now, either observationally, post-marketing, and or even do some clinical translational research and look at tolerability, look at actual pills going down, compliance, and figuring out if the costs recouped in the reduced hospitalization to a drug that might be better tolerated is actually a better healthcare bargain than a less expensive generic that people are less willing to take. And I wouldn't know the answer to that. It's a perfect equipoise time for a comparative effectiveness trial.
Roger, your son has 11 years, is this correct?
That's correct, just turned 11.
Now, he didn't prevent people not to use the drug. It's not being used. I mean, we see lots of patients with cardiac failure.
Sure, certainly.
And I always think, how is possible, class 3, class 4, low ejection fractions, and you don't see this type of drugs quite often. I mean, you know, James, why do you think this is happening? What is your view?
Well, in our experience at Hopkins, we have a lot of patients who have been started on spironolactone, and anywhere from 12 to 18 months later, we start getting complaints in the men of pain in the chest, gynecomastia, women, sometimes a decrease in sexual drive. So I think we have alternatives. We have the CHARM-ADDED study with candesartan. So some people may say, once they have a good dose of an ACE inhibitor, they may give candesartan or some other ARB. We have many other tools that people in gyms especially can use for heart failure. But one of the big issues with the Plarinone has been the cost. It's not generic. It hopefully should be going generic soon. And I think when it does, then we'll have a much greater uptake in its use.
Let me ask you, Sunil, there is an issue here. More and more drugs are evolving. Do you think we will need defibrillators? The point that I'm trying to make here is maybe we might shifting into something that is safe and doesn't require these expensive devices. And I'm just putting this example. I'd like to ask Jim on his experience too. Although I must say only 5% of these patients had defibrillators. But I wonder if by using more and more of this medication, with the number of deaths that you are preventing, it might not be necessary it may overcome the use of defibrillators if we use them more often.
Yeah, and I think we've seen that happen in interventional cardiology, where for stable angina, medical therapy should be the first approach. And so it wouldn't surprise me it happens in the electrophysiology world, although I don't think it's going to happen anytime soon. But it does bring up the issue of the cost, because depending on your perspective, devices are expensive, polypharmacy is expensive. From a societal point of view, things can be cost effective. From the patient's point of view, the cheapest thing is to simply not fill your prescription. And that's a very common strategy as we start getting more and more drugs added on top of each other. I work in a veterans hospital where now the patients have to pay a small copay, but by and large drugs are covered. And even in our population, where adherence rates tend to be higher than in the private sector, patients have to choose. They have to make difficult decisions about a basket full of 10 medications. Can I start taking these every other day and get 3 months out of the supply? So, I think that from a cost perspective, I don't think we're very safe yet if we just avoid the devices. I think that there are going to be cost issues with medications as well.
James, there's some difference between coronary artery disease in the way we usually talk about and cardiac failure as an end result, and it has to do with medications. All the statistics in patients who develop a myocardial infarction, they do well. Actually, at 5 years, less than 50% are taking a statin, aspirin, and an ACE inhibitor. Do you think that in cardiac failure, the fact that you feel sick, are you more adherent to 4, 5, 6 medications? Because I think it depends very much how the patient feels.
Yeah, no question about that, Val. And you hit a very important point. I think there are two things that are going on in the heart failure world that is different from maybe Sunil's world more. And one is exactly what you say. There's a lot of symptomatic patients out there, number one. And number two, patients who are asymptomatic, particularly with systolic dysfunction, scare themselves to death by getting on the net and looking at, outcomes which are pretty bad. But there's another thing that has occurred in the heart failure world, and that's quality initiatives, HCAP scores, outcome measures that are vastly more formalized for heart failure. Core measures for patients hospitalized now. 2 out of some 7 are heart failure measures. And I don't see any core measures for cholesterol or for, aspirin for patients with ischemic heart disease or anything. So for some reason, heart failure has been targeted for inpatient core measure review and implementation of guidelines. Now, I say for some reason. The real reason is heart failure accounts for the greatest number of Medicare admissions in the system. So, I mean, it does make sense.
I'll have to disagree with you on 2 points there.
But it's also aging population.
Well, ischemic heart disease has a huge performance measure implementation program. It started as Crusade, now it's NCDR Action. GRACE is a worldwide performance measure issue for ACS. And, as an ischemic heart disease person, I think the reason why heart failure accounts for the #1 Medicare admission diagnosis is that there's one ICD-9 code for heart failure and one DRG.
Well, DRG.
We have one DRG. We've got multiple DRGs for ischemic heart disease. And if you add them all up, we're still #1. It's a dubious honor, but we're still
Okay, I'll take you off the hook, Sunil. But I do think for one reason or another, there's been a little bit more attention to guideline protocols in the heart failure world, specifically.
Good. Renu, I'd like you to give us your view about the study which so much power as the one that we described today, and on the other hand, so little compliance by the medical community in giving this type of medication. What is your perception?
I think this is a chronic illness, and it goes on forever, and therefore I think the way the patient looks at it is that this is going to be a long-term thing, whereas with coronary disease, on the other hand, you put a stent and your pain goes away, and therefore you feel I'm cured. So there is little feeling of being cured by this disease. So I think, yes, you reduce you can increase your exercise tolerance, and that helps you, but still you remain in that failure group. And you have to go back to your physician over and over again. And so I think the patient looks at it from a different point of view.
But the paradox, though, is in cardiac failure, I find the patients taking the drugs. What I find, the physicians are not prescribing the drug that we are talking about, which is quite different than in coronary disease, where the patients feel well and they don't take the drugs. So my question is a little bit to sense, is the medical community really following what the knowledge is? And in this situation, the patient is very receptive, as you mentioned, and you mentioned the same thing, but I don't think we are prescribing it.
Yeah, I agree with that, but quickly, it's not to say that noncompliance isn't a problem, because one of the biggest reasons for hospital readmission is noncompliance to salt and dietary restrictions, water restrictions, and noncompliance with medicine. It's still a problem, but maybe less so.
Maybe you should, people go to restaurants so often, and the amount of salt we consume is huge amount of salt, and what is required.
The issue is exactly that. If everybody measured their weight daily, things would be different. But this is not done. It's a very simple thing to do.
But isn't it a multiformative problem also.
Yeah.
I mean, these patients are on a diuretic, a beta blocker, an ACE inhibitor, maybe an ARB, and then you should add something more. And
you forgot the digoxin, my favorite drug.
I think Roger.
And then they have other diseases. So therefore,
Roger.
Well, in the Ephesus study, we were dealing predominantly with class 3 patients, and I think when people are sicker, in class 3 heart failure, their physicians are more apt to prescribe medications as long as the patients can tolerate them. But I think now with the Emphasis study, the more recent one, we have more of a moderate heart failure group, and I think physicians will feel like they should prescribe this aldosterone blocker now in this type of population who's less symptomatic than what we saw.
Particularly with this kind of data.
Exactly. Things have changed since my son Ross was born.
Yeah.
Also, insurance will help. The fact that everybody will have insurance and everybody will be covered, hopefully, it may change.
I was, by analogy, in a slight expansion, it's actually not a small number of heart failure patients that are still cared for by their primary care physicians. And I think similar to the statin story, it took 10 years of cardiologists and endocrinologists prescribing statins for the primary care physicians to see that it was safe and that it was effective, and that they were then able to follow the lead and not only initiate therapy. A quick question, a combo pill?
Yeah,
why not?
The poly pills, I think, are going to make it finally.
And ACE, aldo blocker.
Exactly.
I think ACE, everything else.
There's a lot of ways to do it.
Very difficult to make it. Let me tell you, we have a poly pill. It took 4 years and 15 million euros to combine aspirin, a statin, and an ACE inhibitor, which we are going to start next year in 5 countries. And from the galenic point of view, it's extremely difficult. This is not like you put 6 drugs together and you use a poly pill. And this is why the pharmaceutical industry is very reluctant for many reasons, but one of the reasons is because, technically speaking, it's very complex at the moment that the chemistry mix.
But an ACE and an aldo blocker, similar to all of our ACEs and our thiazides and our,
No, 2 drugs, yes, but
that's all I was suggesting.
With cardiac failure, we have, there are so many.
It would be the heart failure ACE. And if it became safe enough, primary care physicians would consider it.
I think it will come. If you're asking my opinion, the issue of the poly pill will come, but it will come on an economic basis. To use the 3 drugs I mentioned in coronary disease is $2 a day, and maybe the pill that we will have will be $2 every 2 weeks, 3 weeks, because it's the distribution of the different medications by different companies that makes this a very expensive enterprise. Yeah. Anyway, it's a good point. I think we have to move into the final subject, which has to do with HDL. And I think it's a very interesting one. We have been talking about HDL since we were born. Yes. And we always talk about HDL. But in terms of real action, it's difficult to prove. But I think it's beginning. And the study being presented here is called DEFINE, which is a safety of anacetrapib in patients with or at high risk for coronary artery disease. You know this story very well. Torcetrapib is a cholesterol ester transfer protein inhibitor that by using that drug that inhibited this particular molecule, what happened is HDL went up or raised to about 100, 120, 130, and the patients had increased mortality and all the side effects that you can name. It was very interesting because on theoretical basis people didn't really know why this happened, and finally a consensus, right or wrong, is that that kind of a drug had something else, that inhibiting effect, and alter blood pressure, alter aldosterone levels, have a significant neurohumoral effects that might have perhaps had been the risk of the effects that were negative for the drug. Well, people have been persistent, and now we have this one. The study being presented by Dr. Christopher Cannon is a randomized double-blind placebo-controlled type of trial with looking at efficacy and safety profile of the drug that we are talking about, anacetrapib, in patients with coronary heart disease or at high risk, who actually are taking a statin and they have the LDL at the right level. And this was compared with the placebo. And the primary endpoints was the percent change in LDL, because these drugs lower LDL, and raise of HDL over a period of 24 weeks, and then at 76 weeks, looking at the risk profile to see if the drug was harmful or not. The results are very positive, very interesting. The number of patients that entered into the study is over 1,500, and the LDL levels were reduced from 81 milligrams per deciliter, 2.1 mole, to 45 milligrams per deciliter, 1.2 moles. This is LDL. And then we have with the control group, there was very little difference. And that's the HDL in the treated patients with the drug was from 41 milligrams per deciliter, or 1 mole per liter, to 101 milligrams per deciliter, 2.6 millimoles per liter, little change in the placebo group. So from that regard, it's spectacular, as it was the previous drug. But what is interesting is that the follow-up that was done at 76 weeks, there was very little side effects, actually. There was no difference between one group and the other. And they certainly look at cardiovascular events occurring 2% of the anacetrapib group and 2.6% in the placebo group, but there was no power to make any comment in this regard. I think this is fresh air in a field that we have been talking for years. Is that right, Noel and Roger?
Definitely.
We talked many times about this.
Our friend and colleague Steve Nissen was doing somersaults about this study. He was so happy, and he thinks that this will be a game changer, because in the great IVA studies that have been done in the Cleveland Clinic, the most powerful factor predicting a modest reversal of atherosclerosis, a decrease in percent atheroma volume, is the increase in HDL. There's no change in aldosterone with this drug. There's no increase in blood pressure. So the negative effects that we saw with torcetrapib don't seem to occur here. And Rory Collins, your friend in the Oxford group, is going to do hopefully the definitive clinical trial, and hopefully in a few years we'll know the real answer.
This is wonderful. I think this is really good. I think this is the beginning of a new era in HDL. Noel, what are your thoughts?
I was particularly pleased with the safety. They randomized about half of the patients had CHD and half didn't, but had elevated risk. And they did have about a 2.5% major adverse event rate, so it wasn't a low-risk group. So I would feel very comfortable going forward with a big trial. I think it's interesting now. It's going to be a proof of concept trial, because the LDL will be lower. Well, we'll have to see the trial design, but the LDL will be significantly lower. And so will this really be a test of raising HDL? And they could put in a third arm if they wanted to test that, and we'll see. I haven't seen any trial designs. And having walked out of a sub-ancillary accord analysis this morning, you know, raising HDL with other agents doesn't do very much. And I think we still don't really understand HDL. And so I think it's going to be a proof, for me as a scientist, a proof of concept trial, but it's going to be an imperfect proof of concept. Hopefully it'll be the HDL drug and it will save lives, and maybe at the end of the day we won't care so much. So I have best wishes for this big study.
And that it will be less falderall. Mm-hmm. The problem with trying to attack HDLs today is, as you said, you don't get much bang for your buck,
yep.
and it's trouble.
Yep.
Renu, after the studies we are presenting today, you will not have autopsy material.
No, I don't think that'll occur. I am not convinced, I'm with you, I'm not convinced that HDL raising it so high really will make that much of a difference.
Well, it's a good point. Functionally speaking, we don't know what molecule we are talking about.
We don't know, yes.
It's true, and you know, niacin, I think pretty clearly from the Coronary Drug Project, from the HATs, from the FATs, clearly reduces atherosclerotic burden, and save lives. So that does a lot. Niacin does a lot of complex things. HDL may be a core part of that, but may not be. And
Lars,
we'll see.
are you going to convert yourself from the clotting to this business after what you heard?
I would like to go with both, but I share the other's opinion. I mean, having been work on this with the LCAT enzyme and HDL, when I wrote my thesis many years ago, it's like seeing things coming back again. But much of this will depend on what happens with cholesterol transport. And it's really the rising of the HDL. It's the same if you do it by alcohol, if you do it by estrogen, if you do it by exercise, if you do it by influencing the cholesterol ester transport protein. I doubt that. It might very well that you hamper cholesterol transport by certain of these. And I think it's the cholesterol transport and the turnover and what goes from the tissues, etc. And maybe HDL level alone is not a good indicator.
Roger?
I think hopefully by this time next year, Greg Schwartz from Colorado will be presenting his work with the Roche CETP inhibitor in acute coronary syndrome patients. So we won't have to wait quite as long for Rory Collins, because I think Greg Schwartz will give us the information, hopefully the cardiology show next year.
There are a number of studies now that are going. Before we conclude, and what I will do in a couple of minutes is to ask each of you what really you take from the studies that we presented or we discussed. What is the most important thing that you take home? But before I ask this question to each of you, I just want to point out that there were other few interesting studies. One of them that we cannot disregard is the so-called RAFT study, RAFT, which has to do with resynchronization in patients with a prolonged QRS complex who actually are in class 2, 3 cardiac failure with low ejection fraction, and the results are really very good. And the question is, maybe will not be necessary to put the defibrillator, and the CRT is taking a good role. James says he disagrees with.
Yeah, I sort of boned at that a little bit. I think RAFT, added to the compendium of other device trials, clearly demonstrates that in a less ill patient population and a really wide QRS complex patient population, CRT is an independent add-on to ICDs to decrease mortality. And the debate is going to be, do you put in the CRT, do you put in the ICD, or do you still combine the two? I'm a little bit reluctant to divorce the devices, and unfortunately what I think we're going to see is a lot more third wires going in and a lot more combinations.
Both devices, that's what the future is.
But again, yeah, I agree, and in soundbite, that was another home run.
Yeah. And the other aspect that perhaps is worth mentioning is that there were a number of studies that left us in the air. Omega-3 in the prevention of atrial fibrillation, it didn't work well. The closure of PFOs in patients with cerebrovascular events did not work too well. Genetic studies on clopidogrel, different dosages, did not work too well. This is better, not than saying it's negative. At least you feel more comfortable.
Well, I like that. Much kinder and gentler.
Yeah. Gene therapy on amputation, there was a lot of excitement here. The gene therapy with a specific agent was a growth factor. It didn't work well. I could go on and on, but I think these last few studies I just mentioned, I will mention CRP. Still great questions of what CRP adds to the conventional Framingham study. It came into another large study. Just to say that we have a lot to think and we go back and forth, but I think that today we discuss three very important advances, and I think I feel very, very happy that you have helped us to, at least intellectually, to go over each of them with some detail. Now I'm going to ask the last question. Start with you, Roger. Of everything we discussed today, what will you tell to your 11-year-old?
Mm-hmm.
Well, I'll tell Ross that hopefully we'll put in less devices. We'll need fewer ICDs. We'll need less resynchronization therapy. If we can remember sort of the ABCs, we'll have them on antiplatelet therapy, ACE inhibition, aldosterone antagonists, beta blockade. As Noel has been preaching for many years, we need to improve their dietary and exercise habits and get their cholesterol numbers down. So hopefully if we can get better implementation of the ABCs, we'll have less end-stage heart failure. And now we know that eplerenone seems to be a real winner.
Noel?
I would very much agree. I think that we have a variety of new treatments, and like so many of our preventive strategies, patients are intolerant of one. So to have additional alternatives to warfarin, I think, is wonderful. And I'm really excited about having better and more lipid drugs. And this is our, this will be our second try at a better strategy for HDL, and I'm cautiously optimistic.
Lars?
I think overall this has been a great meeting for congestive heart failure treatment. That has been a great success. That has to be acknowledged with the emphasis, also with the RAFT. I mean, still there was in the emphasis trial a very high mortality, 25% mortality in a kind of intermediate risk population, and I think there is a big unmet need in that population. But we see the continuing development in antithrombotic agents with the new anticoagulants, and we are in the stream of new trials there, and it's a great area for research and new trials in antithrombotic treatment and concerning lipid lowering and atherosclerotic treatment. It's continuously ongoing, and we have great hopes for the future.
Thanks, Lars. Sunil?
I would agree with Professor Wallentin. I think this has been a terrific meeting because science moves forward a few steps and then it moves backward a few steps. And I think the fact that we had so many negative trials reported is actually a great thing. It's the only thing that prevents us from being viewed as snake oil salesmen.
You're an optimist.
I'm an optimist. As an interventionalist, I have to be these days. So, but I think you report negative results, and that's unusual in our field. I mean, the fact that you have negative trials that are making it into major publications is a huge step forward. Right. It allows us to really gain some credibility.
Renu?
I totally agree with what you said, Sunil, that having negative results being reported is extremely important, because I think we learn what we shouldn't be doing, that we don't have to have every time a new drug, just because it comes on the market, we should start using it. I think that's very good. I think for patients with AF, I think it's a very nice thing not to have to use INR all the time. It'll help in the poor countries in the third world, that we will have different drugs. Hopefully they won't be that expensive. That, I think, is the most important thing, that they won't raise our... And HDL, elevating HDL, I still have to believe that, the plaque is going to change, which I don't believe. So I'm more skeptical on that than most of you are.
James?
So down with rat poison, up with aldo blockade, throw in a few more wires with your ICDs, and I think we're going to go a long way. HDL, I love the hypothesis. Been following it along. How could you not follow it at the clinic? And anxious to see some more definitive results.
Well, this is wonderful. I would say that, to me, the most interesting aspect of our presentation today have been you. And for one reason, this is not some kind of a paternalistic comment, but it is always very interesting, people from different fields, when they cross common sense. And that, to me, is what the intellect really works. So I really appreciate, because all of you are different, completely different. You come from completely different scenarios, but what is enjoyable to me is to see how each of you interact beautifully in whatever subject is being discussed. So I really appreciate very much to be with you today, and I think it has been a good meeting and with good outcomes. Thank you all. Thank you, all of you too.